My pleasure to introduce our next speaker, which is Dr. Kosa from Emory University, who will speak on coronary MDCAT for acute chest pain and the ED.
Thanks, Stephen. Preparing for this talk, I actually myself got chest pains. And the reason for that was that I prepared this on PC, which crashed 3 days before the conference. So my wife said, being a radiologist, you have to be on top of the technology curve. Go and buy a Mac. So I did. So wouldn't work, and then somebody suggested buy Office for Mac. So I did. Still wouldn't work. And then I went to the specialist in our department who deals with this, and he said, when is your conference? I said, 3 days. He said, it takes 6 months to get used to this change. I have no financial disclosures, and of course I'm a radiologist, I have no money. If I were to await perfection, this presentation would not have been possible. Objectives of the talk are role of coronary MDCTA in the ER, feasibility and cost effectiveness, technical considerations in the ER setting, difficulties, limitations, reimbursement, and the future, of course. A few essentials for the cardiac imaging are spatial resolution to evaluate the fine anatomical details of the coronary vessels. No matter how large a patient is in size, the coronary artery is still 5 millimeters. To assess for temporal resolution, which is to assess the coronary arteries without motion, and contrast resolution, which is critical for determining coronary plaque composition. Challenges and limitations. There can be challenges because you need to have a consensus and an agreement at the start between emergency medicine and radiology facilities with regard to selection of appropriate patients, and also sometimes the study is not diagnostic. Most of the times it is, but there are these limitations. Heart rate is too high. Sometimes the patient is unable to breath hold. Sometimes the patient is morbidly obese. Severe coronary artery calcification is another example. When the Grafts score is above 1000, it can be difficult. And of course, radiation exposure. It's not sunshine, it's radiation. Management in the ED, I'll briefly go over that. There are approximately 6 million visits to ED per annum in USA with chest pain syndromes or suspected chest pain syndromes. Management is challenging, time-consuming, costly, and can be inconclusive. Acute coronary syndrome includes 3 entities, which is ST segment elevation MI, non-ST segment elevation MI, and unstable angina. 15% of these patients presenting have subsequent confirmation of acute coronary syndrome. 2% would be mistakenly discharged. Standard of care currently is for risk stratification, obviously history, physical exams, serial EKG examinations, chest radiograph, laboratory studies and imaging like cardiac biomarkers, stress echo, and nuclear medicine studies. To look at cost effectiveness, I could find 3 articles and they were along the same line. So the 3 categories of chest pain patients presenting to ED for suspected acute coronary syndrome. The low or intermediate risk is which we focus on for imaging with cardiac CT. 79% of these patients with chest pain are categorized as 0 to 2 score, which is thrombolysis and myocardial infarction. I'll not go into the detail, but this is for the clinicians and the cardiologists, how they assess and how they put the patients into different categories of suspicion, and only 5% of these TIMI low-risk patients have acute coronary syndrome or are proven to have acute coronary syndrome. The analysis of workup, if you look at this chart on the right, the length of stay, if you follow the standard of care, is 25 plus minus 6 hours, and the charges are approximately 7,500 plus minus 2,000. If you include MDCTA with observation, it goes down to 14 hours and cost also goes down. If you stick with MDCTA alone and you've got agreement and criteria that you're going to follow before, so for recruitment of patient for the MDCTA or placement of patient in that category, and then strictly adhere to the result, and the length of stay goes down to 5 hours and the cost is approximately half. Now, with the new healthcare reform, you would want the patient to go home. If you wouldn't want the patient to stay in for 12 hours if the patient is not going to end up getting treated for, in the acute setting, treated for coronary artery disease. Pros and cons of MDCTA. I mean, multiple trials, Core 64, Core 320 accuracy have shown us very good sensitivity, specificity, negative predictive value, positive predictive value. Radiation dose and resources are, of course, challenges. Let's talk about the indications of cardiac MDCTA in the acute setting. Level of suspicion if it is insufficient for catheterization. Sometimes patients get inconclusive treadmill testing and echo, and then after that, the following day, they can present with recurrent chest pain, atypical chest pain. If you're suspecting anomalous coronary arteries, pericardial diseases can present with acute pain. In the outpatient setting, or sometimes incidentally in the acute patient setting, we might find cardiac tumors. Patients also get, in the outpatient setting, left atrial assessment before ablation. I'll show you a few examples of bypass grafts and stents were actually assessed very well with Core 64. Future is myocardial perfusion and plaque imaging, but that would be in the outpatient setting, not of course in the emergency medicine setting. I'll not go too much into the details of the protocol because that could be a lecture in itself. But metoprolol is given aggressively in the emergency setting. A patient presenting with chest pain, and you've discussed your suspicion of patient having an MI. The patients get unnerved, so it is difficult to bring down the heart rate for quality imaging, and therefore you've got to be aggressive with metoprolol. You give them nitroglycerin also, and nitroglycerin can bring up the heart rate, and for that you can administer intravenous metoprolol on the table. The reason we give metoprolol is, you can see, if the heart rate, so the heart rate, you can see if it is 75 beats per minute, your diastolic phase is only 530 milliseconds, whereas if you bring down 50, not always possible, but if you bring down to 50, I'm just giving an example and drawing an analogy, you've got a diastolic phase of 760, so you've got much more interval to get it right and image the heart adequately. Nitroglycerin, just an example, you want to take out the element of reversible stenosis out of the equation when you're imaging the coronary arteries, and that is where nitroglycerin comes in. Just to give you an estimate of radiation exposure, background contributes to 82% of what we all get, which is approximately 3 millisieverts. And then medical imaging, nuclear medicine testing, consumer products, they all contribute to radiation dose. And of course, imaging is a substantial part of that. Imaging the heart, the different modalities which are used or can be used, you can see that the cardiac CT dose has been consistently coming down with the latest technology using iterative reconstruction and Siemens flash scanner. It has approximately been brought down to 2.5 millisieverts, which is less than the background we get every year. Development of coronary artery plaque, as we know, it starts with lipid-rich or fatty streak, as it is called, and it doesn't necessarily stop there. If it is not managed, it progresses until the vessel completely occludes, causing a myocardial infarct. There are different ways to image the heart: prospective, retrospective imaging. Retrospective imaging, you image the heart during the entire RR interval, so you not only get the assessment of the plaque and coronary vessels, but you get functional analysis as well. Functional analysis is not necessary in the acute setting, and echocardiography can serve that purpose as well. Therefore, the norm now is to do prospective imaging, reducing the radiation dose, where you only image the heart between a specified period of the RR interval. If the heart rate is controlled and lower, you do it in diastole, and if it is higher than 70, you aim for the end systole to image the heart. So just to show you a few images of what normal coronary arteries look like, you can see these are pretty images. If there was any disease, there's no doubt anybody of us would be able to pinpoint and say this is where the disease lies and this is where the plaque is. And an example of coronary artery calcium, and obviously if there is too much calcium it causes blooming, as we know, and in a 5 millimeter vessel if there is a lot of blooming there can be challenges. Just to show you what the disease looks like, so this as you can see predominantly soft plaque here, and it's over a long segment of the left anterior descending coronary artery, a little bit of calcium there too. We suspected that this was an acute thrombus, a rupture, which thrombosed. And again, you can see on the axial images, here is the vessel. Sorry. Sorry, I'm still having a little bit of an issue here. So you can see this vessel LED there is a cutoff, and then on delayed images it fills via collaterals. And they went in and did an angioplasty, and you can see the vessel is patent now. Just to show you a few more examples, mixed plaque, some of it is calcified and some of it is soft plaque or non-calcified plaque. And there was a tight stenosis here, as you can appreciate. Patient presented in the acute setting and angioplasty was done and the vessel is patent. Other issues that we can encounter and patients can present with chest pain is a myocardial bridge. And if it is a short bridge, there are no issues, but if it is a long segment bridge, the reason there are no issues with a short segment bridge is because the heart, the blood supply to coronary vasculature is during diastole. So if a blood vessel goes through the myocardium, it gets compressed mostly during systole. But if it is a long segment bridge, there can be issues because the blood vessel remains narrowed as long as it is within the musculature, within the myocardium. So that can hamper with the blood flow if the patient exercises. The blood vessel is not able to dilate as normally blood vessels do. Coronary artery aneurysms, for example, Kawasaki's disease, coronary MDCTA depicts these beautifully. I mean, valvular prosthesis can be assessed very well, as you can see here. If there was a leaflet that was not mobile or not moving normally, or if there were vegetations, you would be able to see it. Coronary artery bypass grafts can be challenging if you were to assess these with angiography, and the reason being that you can imagine that if a patient got a Lima, left internal mammary to LAD graft, or Lima to LCX graft, similarly, right coronary artery to RIMA, right internal mammary artery graft, just cannulating the vessel and the amount of technique and expertise that are required on part of our colleagues, and similarly the amount of repeated injections that they have to do in order to assess it amounts to a lot. Here is a patient that had a left anterior descending to Lima to LAD graft, and you can see these surgical, sorry, I can't get the mouse to work here. You can see these surgical sutures, but looking at the scan, you can assess that the entire graft is patent. The issue was actually in the distal right coronary artery, where there was a very tight stenosis. I'll show you this graft. You can see the entire vessel is patent, the native vessel, and where the graft attaches. The issue was in the distal right coronary artery, and I'll show you. See that, the tight stenosis? And look at this. This is the angio, again demonstrating the tight stenosis. So it wasn't the graft or the previously problematic vessel that was the issue here. It was the right coronary artery. After angioplasty, you can see it is widely patent. So, there can be different types of grafts, and these all can be beautifully assessed. You can see the entire graft, Lima to LAD, and down to the sub-millimeter level, you can document and demonstrate that there are no issues. The vessel proximally was occluded, and that is why the bypass graft was performed. Assessing stents used to be a challenge, not anymore, because the stents are better, our technique is better, our eyes are better, and our confidence level is obviously better with all those. Assessing for another cause of chest pain, single coronary artery in this patient here, and aberrant course of the coronary artery or intra-arterial course of the coronary artery. This is an aberrant origin of the right coronary artery. This is an aberrant origin of the left coronary artery. These can be beautifully imaged with neurotechnology and with low radiation dose. Radiation reduction strategies, there are many in the literature. We've also published a few: heart rate control, KBP, MAS, tube current modulation, prospective versus retrospective imaging, as I said, and reducing or controlling the volume scan or length. Reimbursement for MDCTA, there have been a few challenges. There are 12 Medicare districts in the country, with each having autonomy about deciding which studies they would reimburse. It is called local coverage determination. A committee was formed of the vendors and some clinician in order to try and curtail the reimbursement of latest imaging technologies, including cardiac MDCTA. When I was at Boston working at Beth Israel, I remember there were some issues. Reasons given for curtailment were that unless the efficacy and benefits of these new imaging modalities were clearly determined and documented through research, these would not be brought into the clinical arena. Core 64, Core 320 accuracy, and several other trials and publications have successfully demonstrated beyond doubt the value of cardiac MDCTA, especially in the acute setting. Coronary MDCTA versus triple rule out, these are different protocols with different contrast dynamics. For the coronary, the bolus is targeted to the left circulation, and we try and clear out the right heart so that we don't get artifact. For the triple rule out, both right and left circulation should be well enhanced simultaneously to evaluate the aorta, pulmonary and coronary arteries. The only issue with triple rule out is that it is almost twice the radiation dose of coronary artery imaging alone with MDCTA, which is not substantial these days. The good thing is that we've come down from 22 or 30 millisieverts in coronary MDCTA to 2.5 millisieverts. So that is good. And therefore, patients who have low clinical suspicion of PE or acute aortic syndrome, especially younger patients, dedicated coronary imaging has been suggested with radiation reduction techniques. Coronary MDCTA versus high specificity troponin, as one of my friends was very kind to mention to me, so I brushed up on the literature, read as much as I could. High specificity troponin is very sensitive but less specific. It also may be elevated in the absence of significant stenosis. CTA therefore can rule out significant stenosis. CTA can clarify also in the acute setting non-cardiac causes of chest pain. New high sensitivity troponin tests have not yet been validated in US, and litigation consequences of a missed MI would make it difficult to implement such a strategy in the US without further validation. So we would need prospective, at least a few prospective trials, if not many, in order to make sure that this really works and this is foolproof, because in MI setting or stroke setting, you cannot settle for anything less than foolproof. Otherwise, we lose our licenses, we'll get sued, And I already don't have any money to begin with, so I can't give anything, In conclusion, MDCTA accurately detects and non-invasively establishes or excludes obstructive coronary artery disease. MDCTA has the potential to substantially alter the algorithms used for chest pain assessment in ED. MDCTA of coronary arteries performs good, excellent in the diagnosis of CAD in the acute setting and can be used for early exclusion of acute coronary syndromes in the emergency medicine department, and multiple meta-analyses have shown that. Acknowledgements, people who have helped me with this talk and people who have helped me in general throughout my life, so I would like to thank them. So objectives of the talk as we went through them. Thank you so much.